Well, thank you again. I appreciate the chance to talk. As people know, I love talking about pediatric palliative care and hospice. I know I gave this lecture last year. I think last year was the first time actually when I sort of discussed more about concurrent care, which I think is a very relevant topic because, as I'll talk about, while we have some dedicated pediatric services in the state, there's also areas that are not sort of covered, and probably all of your hospices at different times, those of you involved in hospice care will be asked to take care of pediatric patients. And my big ask is to just say yes. And if you need help, reach out to Pete's folks to help figure out some of these details, because I'm passionate about kids getting the right care. And it breaks my heart when we can't find services for kids, depending on where they live. So I appreciate everyone's attention today. As always, I appreciate being put next to or right behind wonderful lecturers like Lynn McPherson. I think you guys did it to me last year as well. So thanks for setting that bar high when I come in to talk. So this conversation is about concurrent care and pediatric hospice in general, and concurrent care in particular, how to navigate it. And as I think I did last year as well, while it looks like a compass, it actually is more, why doesn't it work? How do I advance? There, more like a roller coaster. Because in my experience, very few times is hospice in pediatric patients actually straightforward. Sometimes it is, as we'll talk about, a very low length of stay, and it's kind of straightforward symptom management until a child dies. But many times, especially with concurrent care, it's much more of a roller coaster, as I'll explain as the morning goes on. So the objectives today, I'll review a little bit about hospice data and death and dying in childhood in general. A lot of conversation around concurrent care and the Affordable Care Act, and why I both love and hate not the Affordable Care Act, the concurrent care component of that. How it's wonderful, but also very challenging, as we'll talk about, and as well as identify some resources to help people who don't do this a lot say yes to those PEDS patients, including when concurrent care may be involved. So I like to start with a patient description, and I think this is part real, part conglomerate patient of a very, very typical patient that we're asked about when it comes to hospice care. So this young man is a 6-year-old with severe neurologic impairment due to a rare genetic syndrome with chronic respiratory failure. He's trach vent dependent, has a seizure disorder and G-tube dependence. He's been declining over the past 6 months with frequent hospitalizations for recurrent pneumonias, worsening seizures, and feeding intolerance. Recently found to have new heart failure related to his genetic condition that's not been responsive to medical therapy. And the question is he hospice eligible? And obviously, you probably know the answer already, but I use this case to describe, while he may sound complicated in lots of different, this is a very typical patient that we see, in particular with the severe neurologic impairment and genetic syndrome and seizures and eventual trach vent conversations and things. So a very, very common combination of things that we're faced with and trying to figure out when is hospice appropriate and when is hospice appropriate. So stepping back a bit, I'd like to just talk about pediatric death in general, just as far as, what kind of kids are we seeing on hospice, and what do kids actually die from? This is data that many of you probably are aware. If you look at infants under age 1, the most common cause of death are congenital malformations. The CCC part of this table are chronic complex conditions. So if you take out those kids that have severe, like anencephaly, for example, where a child will pass away nearly immediately after birth if they survived a birth, those chronic conditions in infants that lead to their death are cardiovascular, again, congenital and genetic, respiratory, neuromuscular. If you look at all other kids, which interestingly enough, this is from NHPCO, they use up to age 19, which is just an interesting place to land as opposed to 18. All children overall, as many of us know, the leading cause are accidents, suicide, and assault, or that would be homicide. If you look at the medical conditions on the far right there, malignancy, neuromuscular, and cardiovascular are the top 3. And this mirrors really what we see, understandably and obviously, in our palliative care world. Neuromuscular, as it notes, includes static neurologic and neurodegenerative conditions. That is a giant, I think, category of kids that have, I would argue, genetic conditions that all have some sort of neurologic component, be it seizures, hypotonia, weakness, all those kind of things. So that is a giant component. And as I'll point out later, that's actually the biggest component that we see in our palliative and then hospice service. It tends to be those kids over time. Interesting in that same data, when looking at deaths at home, I could not find the newest data on this. This is a bit old now, but I just like to point out the increase in deaths at home by age group. And I think this has to do with better services, better availability of hospice services in the home over the last 20 years for pediatric patients. We'll talk about how that's still a bit of a challenge. I would love to see the newest data to see, okay, are we doing even better now? That being said, that's not the family's goal all the time. So just because they're on hospice, it may not mean that death at home is what they want. That's a different sort of nuance, and bringing them back to the hospital or figuring out where that death might be is a different conversation. But this has increased over time, at least compared to 2000 to 2013 or so. One of the challenges, though, as I mentioned, is the lack of availability of pediatric hospice services. Now, I will say this was a newer graph that I just found in the last few days, or newer picture, which I find interesting of how this data is collected. Because if you look at the state of Michigan, for example, it has a whole bunch of empty spots that say there are no pediatric home services. By home services, they mean both palliative care or hospice, as you can see between the light blue or the green. I take a little bit of issue in that I know for a fact that a bunch of those counties are indeed covered by pediatric hospice services. Depends how you ask the question and how you answer the question. If they mean dedicated pediatric hospice nurses, then yes, there's going to be big there. That most of those counties, I would argue, even further northern Michigan, should be indeed blank. But around Grand Rapids itself, it seems to be that they don't have any. And I would argue that we do indeed have home palliative services because our team does that. So moving away from Michigan, though, I think the bigger picture that this shows is there's a paucity of pediatric hospices across the country. It is interesting that Arkansas apparently seems to do this really, really well. The entire state is covered both by hospice and palliative care. So again, interesting how they answered questions. And the state of Arizona has nothing, which I find hard to believe that there's nothing around Phoenix that would take care of pediatric hospice patients. So I don't know how accurate this is, but it does sort of point out that there's a wide range of available services, and dedicated pediatric hospices are rare around the country. Adult hospices that take on pediatric patients are obviously much more common. And I think even more common are probably adult hospices that actually won't do it. And I know that even in our state, there are some hospice organizations that just will say no because of I think being uncomfortable with pediatric patients and not being willing to entertain concurrent care and all the nuances that I'll talk about in a few minutes. And why is that the case? Well, obviously, all of you know that most hospice patients are much older. So this was, again, a little bit older data, but nearly half of hospice patients, according to NHPCO, are older than 85, and only 5% are younger than 65. I don't know if that data is any different now. 7 years later, I doubt it changed significantly. There's certainly not a huge number of young patients compared to elderly in hospice care. When it comes to our own state, the team that I work with most closely and does have pediatric services in many areas across the state is Hospice of Michigan and their Anchors programs for children. Each year they care for around 80 patients or so, and it fluctuates like any hospice service will. But that's statewide. They have dedicated pediatric teams around Grand Rapids and Detroit and Ann Arbor. Those are the biggest teams just based on population. But their teams in other areas in the state that they cover are trained in pediatrics, which is why I say on that graph, I would argue that there are pediatric services available around the state. And I know many of you also take care of pediatric patients. Thankfully, you will say yes when you're covering other areas like Southwest Michigan, for example. For our Hospice in Michigan population, I have that data. There were 43 deaths last year. Each year, it's probably between 40 and 50 deaths that we have on that team statewide. Average length of service is around 3 months, and it's a bit of confusing data as well because it's rather skewed towards nearly a quarter of patients are less than 7 days, and those may be the classic oncology patient where there's a super late referral, they get home and pass away a few days later, or more commonly even are infants who leave the hospital knowing that their severe congenital anomaly will lead to end of life very quickly and they're home only for a day or two. So that's one end of the spectrum. The other end of the spectrum is nearly 10% have over 180-day length of stay. So it skews the average, obviously. And we'll talk about those patients where sometimes we have very long lengths of stays. My longest right now is a patient who's been on for 3.5 years. A little girl with trisomy 18 who is certainly very eligible for hospice still. But she's been on since day of life, I believe 2 or 3, and is now 3.5 years old. So who are the patients I'm talking about? Just a comment on age. We talk about pediatric hospice, but we certainly don't stop at 18 or 21. We actually are just enrolling today a patient who is 27 years old with congenital heart disease that will not be getting a heart transplant. And since he's been cared for in sort of the pediatric world his whole life, we're taking him on the pediatric side. So that happens not uncommonly in young adults who still have pediatric diagnoses, especially I think from the neurologic perspective. Kids who have had seizure disorders and chromosomal genetic things their entire life, they fit more in the pediatric population. So sometimes we remain involved and admit them through the peds service. I think one of the misnomers about peds hospice and peds palliative care, and now that I've been here with our team for about 9 years, I think we've done a good job of fighting this stereotype that palliative care or hospice is just about oncology patients, especially in pediatrics. And that's simply not true. If you look at the hospice population that we have year after year, it's about 40% oncology versus 60% non-oncology. This is actually, our palliative care service is different. It's more like 20% oncology and 80% non-oncology for some of the more chronic kids that I'll talk about. The non-oncology patients are a variety of different children. Congenital heart disease is one of those. As I mentioned, a lot of neurologic disease, either progressive or static, but with all the complications that come with it. Many of those children have genetic syndromes, and like any good genetic syndrome, have prognoses of maybe most kids die before school age, but long-term survivors have been reported. So anywhere from they'll die early or they won't, kind of thing. So and then a lot of these children, as I mentioned, those last three blend together because these children then develop chronic complex medical conditions, chronic respiratory failure, that kind of thing, with discussions around trach events and all that kind of thing over time. These three children, I've used their picture with permission through through Corewell Health. I do apologize. My slides are not updated to Corewell Health. I apologize to Corewell Health, but I didn't have a chance to switch them all over. But these are three patients that I knew way early on when I started the program here, all of whom were on our palliative care service and eventually transitioned to hospice, and are a good example of a variety of genetic and neurologic conditions that eventually progress to needing hospice and end of life. And for those kids in particular, those chronic kids, where as opposed to oncology, where as bad as we are about prognosticating, sometimes we kind of know once you're at a certain point, yes, this is not going to be curable. For these kids, this is actually what their life looks like. And I borrowed this graph from Joanne Wolf, who was my mentor in fellowship from Boston Children's, about the sort of decline overall of children with life-limiting illness. And each one of those dips may be a hospital stay. You're on the ventilator, barely getting extubated. Eventually, one of those might be the conversation around a trach or a trachea event, and leading eventually to the end of a child's life. Because if we're honest, and we have a problem with this in pediatrics, sometimes we can't cure these things. Genetics is fantastic, but many times we make the diagnosis, but we can't actually change the ultimate outcome. As medicine gets better, perhaps we can push it out. And that's the challenge of that time on the bottom. That time may be 6 months in the NICU, maybe 3 months in the PICU, or might be 20 years, but the end result will be the same. And that's a lot of our palliative care work, hopefully, is upstream of this to help prepare families for that ultimate outcome and decision-making along the way. But the question then becomes is, when do we pull the trigger on hospice in these scenarios as this decline is happening? So before I move on to the concurrent care part, I did want to just comment on, and those of you that have rotated with us, this is something I focus on a lot. What is our criteria for pediatric hospice, as opposed to the adult world, where we've had wonderful lectures about hospice criteria, and there are whole books about this? You won't find the same thing for pediatrics. And I was very relieved a few years ago to realize that my colleagues at Mott use the same sort of three-pronged approach. So I must have learned it somewhere as a fellow, but sort of this three-pronged approach to what how I think about, especially for these more chronic kids, whether it's time to enroll on hospice or talk about hospice. And one is that terminal diagnosis. I always tell folks, your child can't just have diabetes and you're kind of tired of doing insulin, right? You need to have some sort of a serious diagnosis. Now, the terminal part could be questionable. I know over the years we presented different cases where my pediatric colleagues sometimes will question, well, we don't even know if this is terminal or not. And the child, can't eat by mouth, they can't breathe without a machine, and kind of by definition, this seems like a terminal kind of thing. And usually there's a clinical decline. Now, I guess I should put that in quote or make a caveat there, because sometimes it's obvious the child that's in the hospital month after month after month, and the family wants to break that cycle and stay home potentially, as was the case I presented. Or I think the other thing I should include there is it may just be lack of an improvement. So there are plenty of situations where we work with families after a traumatic brain injury or terrible HIE from birth trauma, that they may go home with the trach and vent, but after a year, nothing's better. And it's okay to make a different decision. So I guess I should be careful about the clinical decline, and sometimes it may be no improvement from a horrific injury type situation. And then the third criteria is how a family is going to respond. So for many of these kids, as I mentioned on that graph, on that it's month after month, year after year of hospitalizations, and eventually families may change their mind and say, we know where this is headed and we want to break this cycle. How do we do this differently? How do we stay home and treat what we can treat, but not spin the wheels around trying to cure things that just can't be fixed? And that's where it comes down to this hospice-minded response. Now, we can't tell families you can't come back to the hospital, as I'll talk about with concurrent care, how it makes things a little confusing. But if a family is not hospice-minded at all, I have a hard time saying hospice is a great idea. In other words, if your first phone call when the child isn't doing well is going to be to 911 to call EMS and get back in the hospital to be intubated, I'm a little less likely, or a lot less likely, to say hospice is a great idea. Now, there's some caveats to that in the oncology world in particular, as I'll talk about with concurrent care. I may still do it because I know the disease process is indeed still continuing and they can benefit from those supports. But for the most part, I like to know that a family has a pathway where they indeed would stay home. Could you imagine calling hospice first to have someone come out, evaluate the child, help with whatever symptoms, whatever's going on, and then have that conversation around, do you want further, treatment, evaluation, that kind of a thing? If there is a pathway to stay home, I am much more likely to say hospice will be appropriate to include in your care. So going back to the child I mentioned, this sort of combination of a variety of patients, but a very, very common type scenario we face, is he eligible? I would argue he is eligible now. And why I say now has to do with concurrent care. So before 2010, a child like this who has a tracheostomy and a ventilator and all these different things, those interventions come with a lot of other supports. A tracheostomy typically gets 8 hours of private duty nursing, 5 days, 7 days a week. By get it, I mean it is approved. Finding it is a whole nother story that I could talk about for an hour, about the lack of private duty nursing and how it affects the care of these kids who end up living at the hospital for a whole long time, or families just have to figure it out on their own. So I won't go too far down that rabbit hole. But a ventilator in the same way. So when you have a ventilator, oftentimes those kids qualify for 12 hours of private duty nursing. And so if this is a long-term child who's had a trach and vent since birth, many of these families 5-10 years later will have had the same nurses for years in their home helping them care for their child. Seizure disorders, antiepileptics are expensive. Many children are on 4 different ones, and the newest ones are thousands of dollars a month potentially. These children are still want to see and should see their specialty. There's their specialists, seeing neurology, managing those meds, seeing pulmonary, who's managing the ventilator, and all the other specialists they still see, and chemotherapy, radiation, transfusions, all those things for oncology treatment. If those continue before 2010, all these things on these lists, many of them would have to stop or be reconsidered if you're talking about hospice, because as we all know, paying for all these things from a hospice perspective will become remarkably difficult to not bankrupt one's hospice. So what happened in 2000? Oh, yep. And as I mentioned, so you have to choose to forego these services. As I always tell people who are rotating with us, the trach vent is or the chemotherapy are the easiest ones to think about. That a family who has that degree of home nursing, private duty home nursing, why in the world would they enroll in hospice to have? Now, mind you, I love hospice and the hospice services, but why would you sacrifice your 12 hours a day of home nursing to have your hospice visit once a week? And yes, you're available 24/7. I get it, but it's way different than 12 hours of PDN. So families have to choose, and not surprisingly, families would not choose to enroll in hospice until way, way late, if at all, because they're not going to sacrifice these other things. And oncology is the same example. If we're doing even palliative chemo, many families want to continue that regardless of the odds of it working, and that couldn't happen before 2010. So In 2010, concurrent care came along. I'm sure you've all read the Affordable Care Act and remember Section 2302, which is titled Concurrent Care for Children. You can all read that at your own leisure. But basically, what concurrent care says is that for children under age 21 who have a 6-month prognosis or less, so they meet hospice criteria in general, they are eligible to receive both curative and hospice services for their terminal condition. And I made a mistake in typing that, as I'll mention in a minute. I shouldn't have put curative because it's actually disease directed. I think they say curative in that form somewhere, which is a little bit odd, but it's more disease directed, and that language is important, as we'll come back to. But in other words, hospice can be added to their treatment team in addition to everything they're kind of getting already, which makes it also challenging, as I'll get to. But you can have concurrent treatment that are disease directed therapy and hospice services at the same time. That's what this said. Now, this was a federal mandate. So for Medicare and Medicaid, and in our world, it's all Medicare. I still get that wrong. I'm a pediatrician. I should know that better after all these years. It's all, but it's this only really applies to that population. Which we'll come to as a challenge in a little bit as well. But what the federal government did is basically left it to states then to figure out, okay, this is a mandate now. You have to provide hospice services if families want them in these situations, and they'll pay for it. But it's up to the state to figure out who pays for what. And they left it to each state, which is a little bit of a challenge, and we'll get to that as well. So the requirements in general are under age 21. It's Medicaid or Children's Special Health. Most of our patients have Children's Special Health as an add-on, if whether to their Medicaid or if they have private insurance. You have to fit the criteria of a terminal prognosis, as vague as that might be, as I mentioned. All services that are not covered by hospice must be managed by a pediatric subspecialist, which I'll come to how we deal with that for concurrent care to apply. So I, as the hospice doc, can't be writing for the anti-epileptics and expect insurance to pay for those. They would put that under hospice if I'm the one writing for them. So you do need to maintain your relationship with subspecialists, as we'll get to. Private insurers don't have to honor this, and that becomes a challenge for us. One of the first questions I get from my hospice team is, what is their insurance? Because that makes the conversations far easier if indeed they have Medicaid and or Children's Special Health Care. If they don't, it's a conversation with insurance, and we've had mixed results in whether private insurances will indeed follow the federal mandates because they're not required to. So what does this actually mean? How does it work logistically? Well, certain things are covered by hospice. Certain things are covered by concurrent care, meaning the regular way. Insurance still pays for the other medications and interventions just like they would in any other patient. Again, the best way to think about this is the addition of hospice, not hospice taking over everything, which is, I think, a more traditional way of thinking about it. When it comes to who covers what, I borrowed these slides from Chantel Curel, who I mentioned later on as well, is the nurse manager for pediatrics statewide for hospice in Michigan and is an expert in concurrent care. In general, symptom management medications are on our hospice's responsibility. It kind of makes sense. So pain, dyspnea, nausea, vomiting, all the things we would think about from a symptom perspective are going to fall under hospice care, because that's really the reason to involve hospice, is to help in particular to manage those symptoms better at home, versus as I've said multiple times now, disease-directed therapies. I should probably take out curative, because if you're curative, then you shouldn't be, you don't really have a terminal diagnosis if indeed you're still deemed curative. Disease-directed therapies, whether that's chemo, radiation, infusions, seizure management, that all falls under concurrent care. Medical equipment gets a little confusing, but medical supplies typically fall under hospice, unless it's a ventilator, high flow, long-term BiPAP, those kind of things, transfusions, different drips. So patients at home on millinone drips can be under hospice care and have that paid for separately under concurrent care services. This is actually, again, I know we've all read the Medicaid Provider Manual from the state of Michigan. Section 6.8 is the concurrent hospice and curative care for children area. I remember when I first came to town 11 years ago or so, meeting in Lansing with a variety of other pediatric palliative care and hospice folks to try to figure out what now do we do with that federal mandate that says concurrent care is a thing. They left it, as I said, to every state. This is what the state of Michigan came up with in a relatively straightforward way to say, okay, here's all the different meds, nutrition, respiratory supports, treatments, who pays for what. So this is a convenient sort of table that makes it somewhat clear that pain and symptom management, narcotics, analgesics, antiemetics are paid for by hospice. Tube feeding can be paid for by either, so it gets a little confusing. IV fluids paid for by concurrent care. That is not a hospice plan of care. TPN, same way. Kids can continue on TPN, but that is not paid for by hospice. This is something that I have to share with folks at the hospital quite commonly, as I'll mention when I talk about the challenges around concurrent care, is the IV fluids in particular. When we have oncology patients at home on hospice, they can still come back to the hospital for IV fluids, for transfusions, those kind of things. And many times my oncology colleagues will say, well, they're on hospice, have hospice just do it. Hospice can just do fluids at home. And I'll say, they can have fluids at home. That is a true statement. It's also true that it is not going to be on hospice's responsibility. So I have to be very clear, and it sounds like I'm being mean sometimes, but there's still this perception that hospice just takes care of absolutely everything. And the way concurrent care works is it can't. I can't write for those IV fluids because then hospice gets to pay for them as opposed to the regular insurance route. So this table sort of helps us out in general. It does get a little confusing when you talk about some of the respiratory supports, BiPAP, if it's less than 72 hours or more and whatnot. But there are some things that are pretty obvious. The ventilator, for example, is clearly under concurrent care services. So when a child goes home with hospice services and a ventilator, the ventilator is paid for by the regular insurance path under concurrent care, not expected under hospice to pay for. NHPCO has also tried to help us out a bit in this regard. There's a very easy diagram to follow as far as who pays for what, whether it's a hospice thing or not. I chuckle at that because it seems very complicated. In general, if you actually follow it, it goes back to the symptom management question. Even that can be confusing though, because one could argue, adjusting a ventilator for their symptoms, well, that's a symptom thing, but that's not quite the same as using medications. The medications would fall under hospice. The ventilator itself would fall under concurrent care. So in general, again, it's the symptom stuff that hospice pays for. But there are resources out there to help folks navigate this. But I will say this, I'm familiar with the guidelines in general in Michigan, but every state is different because though that was a federal mandate, they left it to each state to decide. And I don't know how different every state is, but those nuances, the table that I just showed probably looks much different or has differences in even surrounding states to us. So this is actually from this is a nice interactive map that you can reference if you're in a different state or curious about what states look like that talk about what their concurrent care services look like. Again, the fact that every state seems to have concurrent care guidelines would suggest that the map that showed there aren't pediatric services, like in Arizona, was not necessarily super accurate. How does it work as far as the other specialists go? So how do we make sure that, one, they're still involved, and two, they're prescribing the medications so that they're paid for appropriately, not by hospice, but by the concurrent care benefit? This is actually a form that our hospice program sends out when a patient is enrolled, this concurrent care attestation form. So the specialists that are still involved, neurology would be the easiest example for seizure meds, they will get a nice packet of information from the program with a cover letter that explains the patient is enrolling in hospice services, but under concurrent care, they will be continuing to follow up with you for management of their seizures, for example. So it talks about, what they're under the care for, what the diagnosis is, what medications that physician is responsible for. And this is a nice form that then delineates, okay, this is a concurrent care situation. They're still going to see neurology. They're still going to manage the medications as opposed to the hospice team. So this form can be sent out to as many specialists as needed. Now, obviously, when we enroll a child on hospice, part of the conversation is what maybe some specialists aren't as needed. And maybe there is a medication hospice will cover, and is seeing that specialist all that important? So we still have those conversations, but this form is how we make sure those teams, and as you might imagine, this takes a lot of education with folks around the hospital to make sure they understand, yes, the patient's on hospice, but no, they're not just stopping everything. They are still going to be seeing you. So it's been a lot of education with providers of what hospice really means. So obviously, well, I'm biased, but I think concurrent care has been wonderful for many pediatric patients in allowing hospice services to start earlier. And one of the major ones, as you might imagine, has to do with that private duty nursing and those kids with ventilatory supports, whether that's 24/7 or just nighttime vents and things like that. It allows us to have hospice involved way earlier because now you don't have to give up those resources just to be on hospice. So that's one of the biggest areas. The other one is that's very obvious is oncology. So patients who are on palliative chemotherapy that may not be curative or is deemed not to be curative, but might buy some extra time, hopefully in good ways, as well as radiation and transfusions and things that can all continue under concurrent care. Again, as I mentioned, I have to make sure my oncology colleagues are ordering things the right way and understand that this does not just fall to hospice to order. So anything to do with chemotherapy or disease-directed therapy has to be done by oncology. What I have to remind my colleagues is please don't put in those orders that this is palliative chemotherapy, because while that might be true in spirit, if insurance sees that, then it's kind of like, well, palliative sounds a lot like hospice, and shouldn't that not be hospice paying for it? So my hospice colleagues will often remind me to educate folks around that, or curative. So if the goal of chemotherapy is curative, again, that gets confusing to think about involving hospice then. So I have to ask them to instead say disease-directed chemotherapy or disease-directed radiation instead. Patients can still be admitted to the hospital. This is where things get a little bit confusing, but a patient, a pediatric patient receiving hospice care can be admitted to the hospital. Some of this is for new symptoms in oncology. There might be new pain. Are you evaluating for new metastatic disease? Now, if you're admitted for out of control pain, that's going to be harder to sell as a concurrent care admission because their pain management is supposed to be done by hospice. So there's some nuances to this, but if it's new pain and new workup, then we can keep you on hospice and have you admitted. And hospice doesn't pay for the admission. If it's a chemo side effect, fever or neutropenia, patients can be admitted for that. They can even be admitted for chemotherapy. So I personally haven't done this as much as I think the east side of the state does more. From my understanding, Mott does this a lot of kids who are in for a 5-day run of chemo while being on hospice. To me, there's some nuances there as far as, okay, is hospice really appropriate if we're being that aggressive with chemotherapy and side effects and those kind of things. But in general, you can continue to receive chemotherapy. You can be admitted to the hospital while receiving hospice care. This is true for other chronic kids as well. Someone on a ventilator where there's a suspected pneumonia or something new and a family wants that to be treated or evaluated, they can be admitted. It gets a little bit tricky. Again, it goes back to bigger conversations about goals of care and things. The ICU in general is a much harder place to make the argument that this is really concurrent care. If a child is going to be admitted to the ICU to be intubated, I will obviously take them off of hospice. If they're going to the ICU for just a step up and they want BiPAP for a few days and see if it's reversible, maybe we can keep them on. So it's always a conversation with the hospice folks to figure out, is this worthwhile to keep them on or not, and whatnot. But in general, if a family is seeking ICU level care, that's not really in the spirit of hospice, and we may need to disenroll them. So that was what makes me happy about concurrent care, right? It allows us to get way upstream and avoid a last minute admission when the family, is finally sort of willing to accept that chemotherapy may not work, or stop doing chemotherapy, or stop a ventilator kind of thing. This allows us to get way upstream. So it's been a wonderful addition, but it also makes me cringe sometimes and makes me very concerned about how we're using it, because part of the challenges are who pays for what. So again, there's help from the state from different resources about who pays for what. My hospice sort of administration colleagues help me navigate that as far as how do we have to write orders and notes to make sure we're covering things appropriately. Home PT and OT is a challenge. I will say a challenge depending on who is providing it. So there's nothing about concurrent care in pediatrics that says you cannot have home PT and OT, but you will often run into problems, and I will say that this is a problem with our own Corewell Health VNA. They will not provide home PT and OT services to our kids on hospice because they say it's billing out of the same home nursing category, and it's not possible. I know it's not really true because other places in the state have done it. I've had kids cared for in the Alpena area, for example, that get home PT and OT because they aren't able to leave their house, and those are deemed to still be beneficial, and it's still paid for under concurrent care. So it's always conversation and sort of discussions with the different agencies to make sure they understand the nuances of how this is done in pediatrics. One of my biggest challenges, though, is when hospice is used kind of under the idea of, well, nothing needs to change at all. Like, you don't have to do anything different for your child. You just get these extra resources. Now, again, that might be a true statement, but it goes back to what I mentioned in my criteria for being on pediatric, being enrolled in hospice, especially in a more chronic child, is I think there has to be some degree of hospice mindedness, which I think is a made up term. But some pathway where you can use hospice to potentially help you stay home with your child as things evolve. So I do get a little bit frustrated when I have colleagues at the hospital will mention, boy, it sounds like things are rough at home. You could really use hospice because you don't have to change anything. You just get more support. And that's not in and of itself true. There needs to be some conversations about overall goals of care. And I think understanding the terminality of a child's condition. Now, it may not be in the next week or month. We may be wrong about the 6-month thing, but there has to be some level of understanding and acceptance that, yep, we know where this is headed. And there's a pathway where hospice indeed would be helpful, not just from you get some extra help at home, but you're going to be right back in the hospital the next day. That I struggle with. And part of it, I've seen it done before, is using hospice as a path to discharge in a family who's really struggling to care for their complicated, complex child at home. Nothing has changed about their goals of care. Nothing has changed about acceptance of kind of where this is going. But I've had hospitalist teams basically say, boy, we should use hospice. It'll make us feel better if you go home with hospice. And I really get frustrated by that because I don't know that that's the appropriate use of concurrent care. And one other challenge we have is patients who turn 21. Currently, the guidelines are for children under 21. There's some movement to try to figure out if, like the state of Michigan, for example, would increase that to 26 with their newest changes of children's special health now increasing to age 26. There's some hope that perhaps they would increase the age where concurrent care could continue to over 21. Where this becomes a challenge is when we enroll a 19 or 20-year-old on hospice services while they're getting an oral immunotherapy agent for their cancer that's not curative, but is disease directed, and they're doing well in it, seems to be giving them some good time. Overall, they still have the incurable cancer, so they meet the criteria to be on hospice, but then they turn 21, and you have to make the decision, well, which one do you continue? Do you continue the medication or do you continue on hospice? So we've had some interesting ways to work on this, like, hey, you get a 90-day supply, so that buys us 3 months of hospice because you got the 90-day supply before you enrolled on hospice. So now we can have these services on board and have a discussion at the 3-month mark about now what's the next step forward. So not that I'm trying to take advantage of the system, but there's some nuances of how to navigate that. But it is unfortunate that it might be a great benefit for a young adult, but when they turn 21, suddenly it needs to go away. There are, as I mentioned, a lot of resources out there regarding concurrent care. The NHPCO has standards for practice and lots of other resources online that outline the different nuances of concurrent care in pediatrics. And as I mentioned Chantel's name earlier. She is the operations manager for pediatrics statewide for the Hospice of Michigan programs. And I realize that they don't cover the entire state, and there are folks on this in this meeting who do help us with pediatric patients in other areas of the state, particularly around Southwest. There's probably some Centrica folks on. So thank you for saying yes. There are some other pockets in the state where we do struggle still to provide pediatric coverage. But Chantel is a great resource for anybody who might be faced with a pediatric patient and has questions about how to manage the concurrent care part, because it does break my heart, as I mentioned before, when hospices will say, no, we don't want to take a pediatric patient. And at some level, I understand that just from a comfort standpoint. A 16, 17, 18-year-old might feel much different to that hospice team than a 8-year-old, let alone an 8-month-old. So I get it, but I also want to help folks say yes and help take care of these kids who need this wherever they are in the state. And it also bothers me when people say, well, we'll admit a pediatric patient, but we won't do anything with concurrent care. It basically is going to be traditional hospice. We're not dealing with it. That's not fair to these kids and families either. So that's where I encourage folks to reach out to myself, to Chantel, to others who do this more often to help navigate how to do concurrent care to provide the best care for these kids, like I said, wherever they are across the state. So that's really all I have, which is remarkable because I know I usually talk way longer than I'm supposed to. So as usual, there's an updated picture of the kids. That smallest one, that was his 10th birthday. He didn't exist when I first came to town. So now I feel like I've been here a long time with doing this. So I appreciate folks listening. Happy to take questions. As I said, reach out even offline with other situations or questions that I can help with.
Well, thanks, Brad. Any questions for Brad here this morning? I particularly appreciated the note that yes, you take care of young adults even into their 20s. I often thought that that there's kind of an artificial demarcation of age that frightens hospice staff, and it often frightens physicians as well. That when they get past a certain age or below a certain age, as adult practitioners, that somehow we can't touch someone who's 16 or 14 or 8 or 7, when in fact what is needed is not necessarily specialty level pediatric skills, but it's palliative skills. It's the conversations, it's understanding the goals of symptom management and things of that sort. And that transcends artificial age guidelines. But I've encountered those situations in which I've had, I would say more on the staff side than the physician side, but I've seen physicians too that said, I'm not going to touch a kid. And that generates a conversation as to what the fears are and what the concerns are. And a lot of times it's more emotional than it is practical. I have kids of my own, and dealing with a sick kid is something that I just don't know that I could handle. So I appreciate the fact that you touched upon that particular aspect of it.
I think that's a broader challenge, especially as we get, quote, better in pediatrics with some of these disease processes, not curing them, but pushing it out to the adult world. And that's a bigger transition question in general for kids with medical complexities who hit 18 or 21 and are then booted to the adult world. It's a much bigger conversation about how do we care for those kids in meaningful ways when they're not the typical internal medicine patient, certainly, let alone in the hospice world. So as I also said, I appreciate people who are willing to say yes, even if it's an older teenager. And I've appreciated that I think all of us work together to provide the best care for these kids. So I've had kids cared for by other hospices that I have nothing to do with, but a family wanted to go to a particular hospice, and then I still stayed involved in working with. I can remember patients from Hospice of Holland, where a family really wanted to be used by them, and Alice said yes, as long as I would still be involved, and we worked together to make that happen. And I do similar stuff in Lansing, where there's a little bit of a gap as far as pediatrics, and I'm willing to be involved as the pediatric person and help those nurses so that they can say yes when some of their administrative folks are much more nervous about it. So I appreciate that. As usual, we work together. So
yeah, I think that's great. Those collaborative relationships. I recall one. This goes back many years, in which I was at Vanderbilt, and we were discharging a 4-year-old on a ventilator, and they wanted to go home into a rural place in Tennessee, about 2 hours away from Nashville. There was only one hospice that covered it, and they have a census of 5. They basically have one staff person that covered all of the covered social work tasks and chaplaincy tasks and nursing tasks. They had a minister they'd call in now and then, and they had a doc remotely that would take care of the administrative parts of it. But it was just this one person, and I called and explained the situation. She had never taken care of a child before, and but she said she'd be happy to do it. And we knew that the child would die relatively soon. And so we kind of talked through what kind of supplies, what kind of drugs you might want to have in the home. And the child went home on a ventilator to be discontinued once the child got home. And so through that kind of a partnership and guidance, the ambulance left, went home, and the nurse was at the home when they got there, and walked them through the extubation process. And the nurse stayed there at the bedside for 18 hours until the child died. And I probably was on the phone with her about 8 or 9 times during that period of time. But it was a beautiful experience for the family. It's what they had wanted in a very, very difficult circumstance. And so I just would just support that level of collaboration, because it's really, you alluded to this several times, when administrative structures put up artificial barriers that make it difficult to do what's right for the child and the family. And so I think that we need to do everything we can to try to limit those.
Yeah, and I think that story you told is beautiful, and that's why I'm so passionate about Peds Hospice and making those kind of things happen. I mean, death in pediatrics is always going to be shocking and heartbreaking and awful, but also can be beautiful, even in those scenarios where a family's home for hours. Or I had a similar situation where we got a child home with a ventilator, and all they want to do is give the child a bath, and it was a beautiful sort of moment for a couple of hours in the home before the ventilator came out that they would never have had it not been for some of these services. So I think it's a lot of education and reassurance of providers. If it's okay, yeah, this is going to be a heartbreaking, difficult situation, but we can make the best of it. And it does take a lot of resources, but I think it's obviously very worthwhile in my opinion. I will also say, and I should probably add this maybe for next year, or next time I do this, is the other thing that the other huge benefit that I talk to some of these more chronic families about is if you can imagine staying home at some point as your child declines, hospice is the ultimate safety net. Because I think many families are fearful of, well, we know if we go back to the hospital, we're going to be intubated and all this stuff done. So obviously lots of conversations around code status and trying to limit things potentially. But if something happens at home, you have to call 911, right? If your child passes away, you can't. And I'm worried in many situations around, well, what happens next? And I could tell other stories in both directions. In fact, one was related to you, John. You called me about a patient who called you inadvertently when their child died. And what will EMS, how will they respond? Will they feel they have to do resuscitation if there's not a DNR in the house, which there's not really a legal DNR in the state of Michigan for peds. So it makes it challenging. I've been on both sides, an EMS that felt they almost had to and were forcing a family to do stuff, and other ones where they responded to what the family was saying and then my conversation. So I often tell families hospice is sort of an ultimate safety net. If for nothing else, obviously you have to meet the other criteria like I mentioned, but for nothing else, then to provide you peace of mind that if your child passes away at home, you don't have to call 911. It gives you a different path that is going to be potentially a whole lot less traumatic. So, Matt, I see you sitting there. I'm interested if you might comment on Indiana, right? I don't know if hearing what I talked about in the state of Michigan, if that is true in your experience in Indiana as well. I guess I'd be interested if there are glaring differences in your experience that because you've obviously done this for a while with pediatric patients down there.
Good morning, Brad. How are you?
Good.
So, yeah, and I appreciate obviously listen to pediatrics. I could do this all day. I got a colleague right next to me. He's also in the peds. So it's good that some of us are actually wanting to do this work, And I think I'd like to comment on what you're saying. First of all, your map, that was showing basically when I had you palliative care and hospice. So I'm hoping eventually we're going to go completely both, at least in St. Joe's County where I'm at. Because right now it just says palliative care. And it was interesting. I was like, I don't have much palliative care right now because I don't have inpatient privileges. It's all hospice. But anyway, to make a long story short, one of the things that we do in our palliative or our hospice program, which is very similar to Faith Hospice in many ways, and I know that John knows this, including our IPU, which is very similar to Trillium Woods. But one of the things that we do, there's 3 of us, and 2 of us are, like, including my wife's medical director, are just strictly really adult providers. And I love the fact is that we kind of have this working relationship where they just emotionally don't want to do children, right? My wife flat out told me I can't be in the forefront watching a child die or even the demise, right? But what I can do, for instance, I just had a child that just passed, unfortunately, yesterday at 12:30 in the morning. It was a 1-year-old with a history of HIE. I had her in palliative care for almost, she came to me at 4 weeks at a month, and I had her all the way up until about 2 weeks ago. And then we began these conversations 5 months ago about, do you want the G tube? That's where we're heading. No. Did you want a trach? No. To make a long story short, I was at home taking care of the patient at our IPU. Her parents actually wanted to come into our center. But then the hardship for me was, okay, it's Monday and she's still here. She's still with us. And the parents are getting a little bit nervous because I'm leaving. I had to come back up here. But I just told, I told my wife, I said, look, when I was thinking this about other states, like for instance, you're there in Michigan, right? So if you have a county like down in the South, right, and they don't necessarily have pediatric services, just like I feel, you can have a pediatric specialist that's willing to at least take those calls and make those med adjustments. I'm not on site, but that's what I was doing with the Ativan and the seizure control, right? And then, but what was beautiful is though I had my wife come in and do the blessing. You with me? Because that was just as important for me to have someone go in there and do that condolences piece, to give condolences why I couldn't be because I was here. So I think that there's different ways to kind of, for people to engage. You don't necessarily have to think that, oh, I'm going to be the one on site, right? I think that's part of this kind of, I feel is kind of the wall, right? Because pediatricians, we expect to be, me personally, I think, Shiraz, you just want to be on site more than we necessarily can do for an adult, right? So anyway, I don't know if that's what you're kind of looking for. And I wanted to ask you another question, not to make this to bring it to the monetary side, but you brought up a good thing, a good point that, we need to have subspecialists, not only for care, but just kind of delineate who's paying for what, right? But what happens, let's say, if, like, for this patient, for instance, the parents weren't able to get a hold of a neurologist, so I was just doing the refills. Okay, does that, and then of course the expectation is that their insurance, that Medicaid was paying for it. Is that right? I didn't initiate, you with me?
Yeah, it probably depends on how close Medicaid looks at that, because in theory, if they look and see that you as the hospice physician are ordering those, they would charge that. They would not pay. They would say hospice shouldn't cover that. So okay. But to the spirit of that, quite honestly, if that happens and I have a neurologist who just won't participate or whatever, we tend to just do it in hospice, right? We just say yes and they cover it. So obviously over months and months, that becomes a bigger issue. If this is, hey, they need a refill for the next couple of weeks, we just do it. Nobody's making money in pediatric hospice, that's for sure. So these are costly, resource heavy programs, but it's the right thing to do for kids. That's where Concurrent Care helps. So at least for some of these more expensive meds, to be able to have a different way to pay for them. But I think that by the letter of the law, if you're writing for it, it would fall to hospice to cover. But I think we've all done that. I think we'll just say yes and we'll do what we need to do to take care of the patient, almost regardless of the concurrent care part in many situations.